Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Balada from Roots Community Health, reporting for the week of April 14, 2025. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. I wanted to mention that we will finally be having the first ACIP meeting of 2025. That's the Advisory Committee on Immunization Practices, the committee that advises the CDC. So that was postponed and now is being held on this week, Tuesday and Wednesday. So it's a 2-day meeting. I've reviewed all the slides. There is a lot of really good information that they're going to be reviewing there about COVID and flu, among several other things. They will be taking a few votes. The anticipated votes will be regarding meningococcal, RSV, and chikungunya vaccines. But it looks like a vote regarding the COVID vaccination recommendations will be handled at the June meeting. So I'm not going to review any of the slides today. I'll save that for next week's briefing after having the opportunity to hear the committee presentations and discussions. But I've linked the agenda and the live broadcast in the post. So more on that next Tuesday. Today, we've got a number of updates regarding COVID, flu, H5N1, measles. So let's get right into it. First, taking a look at respiratory viruses among patients who present to a healthcare setting for testing. Flu cases in the bright blue continue to come down. And as the percentage of flu cases comes down, some others are making up a larger share, like rhinovirus, enterovirus in the gray, which we can see coming up, not quite as fast as it was before, but still coming up. Also, human metapneumovirus in the black, and a little harder to make out there at the bottom, but in yellow, we've got para-influenza virus, and in light blue, adenovirus. And COVID is in the red. It's still looking relatively flat, and more on that in a moment. If we look at wastewater and emergency department visits, we can essentially see those coming down for COVID. So I thought it might be a little bit more helpful at this point to look at the epidemic trends, which is where CDC uses data from emergency department visits to build a model that helps to tell us whether the number of new infections is likely growing or likely declining by state. And as we can see here, most of the country's either declining or likely declining in the shades of green, or stable in the gray. White means they're not reporting information here. Where in California, we see that it is likely growing. So this is for SARS-CoV-2, likely growing based upon modeling. And this is generalizing for the entire state. So we'll just keep an eye on that. Taking a look at hospitalization rates, we can see that flu continues to decline pretty significantly. That's in the blue. And it's hard to make out, but it actually has crossed down just below COVID, which is the orange line. So as of April 5th, COVID-19 hospitalizations are 2 per 100,000, while influenza is 1.9 per 100,000. So just very slightly less than COVID, but certainly heading in a direction which we can anticipate will continue to dip below COVID, while COVID stays flat, hopefully stays flat or declines, but also could potentially go up because we know that we've been seeing at least a couple of COVID waves every year so far. But if you look over to the left, you can see that in mid-December was when the blue line crossed over the orange line. So basically, we had more flu hospitalizations than COVID hospitalizations between December 21st and March 29th. So just a little over 3 months. And this is fairly consistent with what we normally experience in terms of the time period for the highest burden of flu. But this is the first time since the onset of the COVID-19 pandemic where flu has really surpassed COVID in any sustained way. So a little over 3 months, more flu than COVID hospitalizations. So this might be something to expect in the years to come during so-called respiratory virus season, so we will see. When we take a look at the number of COVID deaths, they have been declining for going on about 10 weeks now. So this is showing us through mid-March. And so this is good news, and we certainly hope to see this trend continue. When it comes to the number of deaths, and I've talked about this many times here, we know that the gray shaded bars are preliminary and they do predictably go up significantly every week over week as more death certificates come in. So the gray bars are definitely subject to change, and they only increase from what we see here. So these are confirmed based upon death certificates. So as more death certificates come in, they will update even the bars that came before it based upon the date of death. So it is coming down. 466 deaths so far recorded for the week ending March 15th. Again, we anticipate that'll go up a bit. So we're looking at around 2,000 people per month still dying from COVID. So this is still a lot. We still have a lot of work to do here. I'm going to talk about that a little bit more in a moment. Now we're looking at percentage, so not numbers of death, but percentage of death from COVID, flu, and RSV. And this is percentages compared to all the deaths. And so if you look all the way over to the right, we can see that flu deaths in the blue are actually equivalent to COVID deaths in the orange. And so this is the first time after about 9 weeks of flu being more, causing more deaths than COVID. And I wanted to point out that the gray shaded area here, it is technically preliminary, but unlike the number of deaths that we just reviewed in the previous slide, the percentage of deaths is much less affected by incomplete reporting in recent weeks. And that's because, again, we're looking at the percentage compared to all of the deaths, and death certificates all have similar timelines for just about all of the causes of death. So we really don't expect the percentages to change significantly. And that is consistent with what we've been seeing week over week, with this graph really not changing when we look at the bars in subsequent weeks. So what we're seeing is that we had about 9 weeks where there were more deaths from flu than COVID. And of course, this leaves another 43 weeks of the year where there will be likely more COVID deaths than flu deaths. So basically, the leading cause of death from a single infectious agent in the United States is COVID almost all year round, ever since the onset of the pandemic. But we might expect a couple of months where flu surpasses COVID as a leading cause of death from a single infectious agent. So, of course, in the United States, it looks different than other parts of the world where we have TB and other things that are more leading causes of death. But here in the United States, this is really what we're grappling with as leading causes of death from a single infectious agent, COVID, almost all year, and a couple months where it's flu, and we'll see if this is a trend that replicates in subsequent years. And we know that in order to mitigate this, we have treatment. And if we test timely, then we can get to treatment timely. And for most people, the most appropriate treatment is going to be Paxlovid. So basically anyone 50 and up and anyone with underlying conditions, which is estimated to be about 75% of the population. And this is something I'll go over next week in more detail. But many people have an underlying condition that puts them at risk of a bad outcome from SARS-CoV-2. So Paxlovid for most people, if there are drug-drug interactions that prevent your ability to give Paxlovid, and this is pretty uncommon. Most medication interactions can be dealt with by holding the medication, but every now and then you do run into something where you just cannot stop that medication. And in that case, you may have to look to something like molnupiravir or remdesivir. And then for immunocompromised individuals, it is possible that high titer convalescent plasma is going to be the best treatment. Now, these are outpatient treatments. I wanted to share today a study about all of the authorized treatments for COVID-19. So this includes inpatient and outpatient, but this is a rapid systematic review of US FDA authorized COVID-19 treatments. And this is a publication from Open Forum Infectious Diseases, published April 11th, 2025. A reminder that a systematic review basically synthesizes research on a specific topic, and it's looking to answer a specific research question, but is basically scrubbing the literature for studies that will help to add to the body of information that can help us answer the question. So it's synthesizing a number of different research studies. And a rapid systematic review does this in a little bit more streamlined manner, usually more time limited. And what the researchers here were trying to identify was whether any of our COVID-19 treatments were associated with serious adverse events, and if so, which populations were most at risk. So very, very important question. Of course, we have the original clinical trials from each of these drugs, but we're always wanting to continue to look at more information as we have it, because once it gets out into population, we have many, many more patients that are treated. And so we can find the more rare things that are happening, or we can help to confirm what we may have found in the original studies, or get some more nuanced information about different subpopulations. So 54 different studies met the criteria to be included in this review, and 31 out of the 54 studies were randomized controlled trials. So that is the gold standard for evaluating medications. And most or more than half of the studies in this were randomized controlled trials. So what did they find? Well, when it came to our antiviral treatments like Paxlovid, Molnupiravir, Remdesivir, there was no evidence of association with severe adverse events. So this is very good news. And of course, this is what we have seen in previous studies, but this is even more evidence pointing to the fact that there are no serious adverse events with these antivirals. When it came to hospitalized patients and taking a look at some of the infusion treatments, then we started to see some things. So there was some elevated risk of serious adverse events with the monoclonal antibody tocilizumab. And those events included a very low white blood cell count and also possibly increased risk of infection. And when it comes to convalescent plasma, there was some indication that there might be a possible association with clotting events. And in patients with blood cancers, it may be associated with bleeding types of events. So once we started talking about sicker hospitalized patients and those with more serious underlying conditions, it, of course, does become a lot more difficult to sort out whether these events were a result of COVID-19 or of the treatment. So more study will definitely need to be done. There will need to be continued vigilance when it comes to treating some of these subpopulations and also when using some of these treatments. But I think there was a couple of reassuring things here. First off is that with this systematic review, again, no serious adverse events with any of the antivirals compared to placebo. So none of the antivirals that we give, none of the outpatient treatments that we give had any serious adverse events associated with them. Not the first time we've gotten this result. There's been other meta-analyses as well as a number of clinical trials that have also shown this, but it's always reassuring in a large systematic review like this that these findings are reproduced. It's also reassuring that the serious adverse events that they did see, like with tocilizumab and with the convalescent plasma, those events are actually already included on the product labeling for these drugs. So this is important. Folks that are giving these medications are already aware, but still something to make sure that we continue to stay on alert. There were a few limitations of this review. I won't go over all of them, but one of them is that they included only studies that were done inside of the United States. So there's definitely some benefits to that. But had they included studies from other parts of the world, perhaps this could have bolstered the findings, could have changed the findings. So just something to keep in mind. Also, they were unable to parse out some things. And one of the most significant is probably that they really could not parse out significant adverse events in different age groups. So this will be something that we might want to be on the lookout for the future. The bottom line here is that approved treatments for COVID-19 should continue to be prescribed as indicated. Of course, a lot of medications have side effects. We need to be aware of what those are. We still must be on alert, particularly for those adverse events that are already indicated on the label, and especially in sicker hospitalized patients that are receiving infusion kinds of treatments. Definitely when it comes to outpatient treatment of COVID, timely testing, timely treatment reduces the risk of hospitalization and death, and we should not be withholding these treatments. So primary care doctors need to be learning how to manage Paxlovid prescriptions, what medications they can hold in order to give the Paxlovid, or when they really cannot give Paxlovid and when they need to go to one of the second or third line agents. And please remember that concerns about rebound of symptoms or a return of a positive COVID test, it's understandable to be concerned about these things. They're very annoying, very inconvenient, but at the same time, it does not change the fact that these medications do what they're supposed to do. They reduce the risk of hospitalization, reduce the risk of death. So we should be continuing to utilize them. And even when there is rebound, the rebound itself is not correlated to any worsening of the patient's outcomes. So we definitely should be continuing to use those treatments for those who are eligible. And regarding flu, so far this season, we've seen about 46 million flu illnesses, 590,000 flu hospitalizations, and 26,000 flu deaths. And this includes 188 pediatric deaths. So this is pretty devastating. This is 20 more pediatric deaths added just since last week. So we're continuing to lose some little ones to flu. This is too many children lost to flu. The vast majority of them were unvaccinated. And now that we're getting towards the end of the season, we will be getting more specific data from this season about how well the vaccines this year performed. And in this week's ACIP meeting, they will be reviewing that. So I will be looking forward to hearing more about that and reviewing it next week. And now for a brief update on H5N1. There have been no new human cases detected in the United States since I reported last week. So still 70 human cases. As a reminder, 3 of them were from unknown source. The other 67 came from an infected animal. More than half of the human cases, so 38 out of 70, were in the state of California. And just a reminder on how they're doing the surveillance right now. So in flu season, there's a lot of flu testing going on through the National Flu Surveillance System. CDC is reporting that over 179,000 specimens were done that would have detected H5N1. Out of those 179,000 tests, there were 6 positives detected. So very, very, very tiny fraction of a percent there. But then there's also targeted surveillance, and the targeted surveillance efforts are around animal outbreaks. And this is what has yielded the majority of our positive cases. So out of about 880 people tested, they have picked up 64 positives. So that's about 7% positivity rate. So it seems as though the targeted surveillance efforts are working. So it will be interesting to see if those get ramped up over time, especially as we anticipate that the flu surveillance will drop drastically because there's not a whole lot of flu circulating, or there's a big decline in the amount of flu circulating at this time, and it will go down to practically nothing before we head into next season. There has been the one U.S. death from H5N1 so far. That was in the state of Louisiana. And remember that the gentleman who died in Louisiana had the same, more or less, variety of the H5N1 that caused a young girl in Canada to become critically ill. And last week, I reported on Mexico's first human H5N1 case. This was a 3-year-old girl. Sadly, she has died. And it hasn't been determined where she contracted the H5N1, but 38 potential contacts of hers all have tested negative. And so there doesn't seem to be any human-to-human spread still in any of these cases. We still don't seem to have updated information on the sequencing of the virus that infected this little girl, but hopefully we will hear more about that soon. In particular, I think we'd like to know, does it harbor the same mutations as the virus in the other 2 serious cases that we've seen so far? So we will report more as we have it. Some better news regarding H5N1 is that the FDA has granted what's called fast track designation for a vaccination to prevent H5N1. The phase 1 trial started this past November, and FDA recently granted the fast track designation based upon the fact that we have an unmet need. Yes, unmet need, because we do not have a vaccine for humans against H5N1. And since this outbreak amongst our cattle and poultry, including jumping to human beings, has gone on since March of last year, it does seem high time that we get some movement on this. So the company developing the vaccine is called Arcturus Therapeutics, and they expect to have some data to report back in the second half of 2025. Right now, they're really focusing on evaluating safety as well as the immune response that is mounted after the vaccination. And they'll be comparing this with other flu vaccines out there. They'll be selecting the most appropriate doses and the vaccine schedule and so forth. So this does seem to be a positive development, getting us closer to pandemic preparedness as it relates to H5N1. In the meantime, it is still the case that the main risk to humans is to those who are working with cattle or poultry, but still important that we all understand the potential risks. So we should avoid consuming raw milk products and undercooked meat. Please don't touch any wild birds or dead animals. Tell your children, guard your pets, and those working with cattle or poultry need accurate health information. They need proper PPE. They need up-to-date information on their industry standards or guidelines. And now for a measles update, more sad news to share on the ongoing U.S. measles outbreak. There has been an additional measles death connected with the West Texas outbreak, and this is in a 31-year-old man in Mexico. So it seems that there has been a significant outbreak in the state of Chihuahua, Mexico, where there have been at least 261 cases confirmed. Apparently, a member of the Mennonite community became infected in the United States, in Texas, and then upon returning to Mexico, apparently, reportedly, spread the virus to other areas of the state. And the 31-year-old man who recently died resided in the Mennonite community, and his case is linked to the outbreak that is occurring in the state of Texas. So because this man died in Mexico, I anticipate that we will not see his death counted as part of our outbreak, but it is in fact linked. And I think it's important to acknowledge that. In the United States, we tend to get concerned about other parts of the world where they may have poorer control of infectious diseases, but now we see that things are changing, and we are, in fact, the ones that are posing health threats to other parts of the world and ourselves. And so it is the United States that has been hosting a massive H5N1 outbreak among poultry and cattle, and presiding over its spread into humans. Now the United States has pockets of low and declining vaccination rates, Yet we here in the United States tend to do some of the most traveling to other parts of the world. So it will be interesting to see how other countries respond to this new reality. So the outbreak that began in West Texas has now spread to multiple counties in Texas. It has spread to neighboring states and to neighboring Mexico. As of this past Thursday, April 10th, there are 712 confirmed cases. That's up over 100 cases, so up from 607 cases reported last week. Thus far, 79 individuals have been hospitalized. There have been 3 deaths, really 4 if we rightfully count the man who died in Mexico. The 3 we're reporting here are 2 children and 1 adult. It is notable that 93% of cases, so 660 out of the 712 so far this year, are outbreak associated. So by comparison, in 2024, only 69% were outbreak associated. So measles is establishing itself with local transmission in many areas of the United States right now, meaning we are in an unpredictable situation. And in particular, those areas with low vaccination rate are at risk. Here in California, we've had about 9 cases that are not causing local transmission or spread. These are essentially imported or brought in from folks who travel from other areas and then not establishing themselves. That's what will happen in communities of high vaccination rates. But the same scenario in a community of low vaccination rates, it is a whole different story. Last year, for the entire year of 2024, there were 285 cases. So already in 2025, we have about 2.5 times the number of cases that we saw the entire year last year. So really heading pretty quickly in the wrong direction here, and no indication that is slowing down at this time. And this outbreak is disproportionately affecting young people. So far, 70% are in children 0 to 19. So that's those first 2 bars on the left there, 499 cases out of the 712. And about a third are in children 0 to 5. So 225 or 32% are in children 0 to 5. And these are very vulnerable young people. Their immune systems are not fully developed. And most of the time, they're also not fully vaccinated yet. So even for those who are vaccinating their children, they may have only had 1 dose, for example, so far. And we know that there is a significant risk to these children, and particularly if they are unvaccinated. And we're especially worried about babies 6 to 12 months. They're especially vulnerable. If you will be traveling, or if you're in an area of low vaccination rates or of outbreaks, this is something to really talk to your child's pediatrician about. You may want to start a vaccination series early. You're still going to have to get the 2-dose series, but you may want to do an extra dose between 6 to 12 months if you think there is a risk of exposure. And remember that measles can look like a lot of other things initially, but then the rash, that distinctive rash, will show up on the face and work its way down the body. The time of high contagiousness is 4 days before the rash and 4 days after the rash. So it's important to document all of these things and contact your doctor or your public health department immediately if you suspect exposure, or if you suspect that you or a loved one has measles. Reminder that measles can lead to respiratory failure, brain inflammation, can lead to permanent brain damage, and it could cause blindness, deafness, causes death in 1 to 3 per 1,000. We're seeing a little bit higher death rate than that so far, still early days, but what we've seen in the past is 1 to 3 per 1,000, even with the best medical care. Also, even if you recover okay from the initial measles infection, it can wipe out parts of your immune system, so you become susceptible to more infections even after recovering from the measles. So we really want to maintain all of our best practices overall for preventing the spread of illnesses, especially those spread by the respiratory route, highly contagious. So let's keep up with the vaccine recommendations. Wear a high quality filtration mask. If you are going to be mixing with others indoors, gather outside as much as possible and pay attention to indoor ventilation. and filtration. And we're going to want to recognize symptoms as early as possible to get tested, get treated if it's appropriate, isolate from others, and so on. We also want to make indoors safer for everyone. So healthy building best practices includes improving indoor ventilation and filtration and doing all of the things that we know to keep those indoors safer. And this includes our places of work, other venues, our schools, and so on. This is still a huge responsibility that we all should be taking very seriously. So let's continue to stay informed, do what we can to keep ourselves and our loved ones safe and healthy. Remember, if you don't have a primary care provider, please get one, develop a relationship with them, make sure you're getting the appropriate screenings and vaccinations based on your age and risk factors. Try to eat a balanced diet with whole foods, fresh foods, quit smoking, limit alcohol and sugars and processed foods and artificial ingredients. If you don't feel well, make sure you get your rest. Otherwise, get some regular physical activity, get some fresh air, manage those stress levels, and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us. We'll see you next Tuesday at 10 a.m.